everyone. My name is Amy Scott. I'm the CEO of CrossFit Hope, and I want to thank everybody for being here, and those of you who are joining us online. So tonight we're going to be talking about the hidden burdens of cancer, and we're going to have our panel led by Bill Beach, and Dr. Rhodes, Dr. Fennesar, and myself. And hopefully you'll be able to join in the panel discussion and ask questions and contribute to the conversation. So with that, I'll hand it over to Joel.
Great. Thank you very much, Amy, and welcome everyone. As Amy said, I'm Joel Beach. I'm a board member at Crossroads for Hope, and I've been working with Amy and her organization official capacity as a board member for about 9 months or so. Over a year now, and I'm familiar with time goes really fast. And I've been associated with her organization for quite a long time, but it's been an honor to be part of the organization. And Amy, thank you very much for bringing me into this conversation with these two fantastic doctors at this great facility. So as Amy said, we're going to talk this evening about the hidden burdens of cancer. And talking to Dr. Manazar as we started off the evening, cancer sucks, no matter what you say. And when you get the diagnosis, you don't hear much else, but we also want to go a little bit deeper into what is actually happening. Are there burdens that we're not talking about? Are there burdens that we need to address straight up? Are there burdens that physicians face? Are there burdens that patients face? Are there policy burdens? Are there insurance burdens? So we're going to spend a fair amount of time talking about those challenges. But I'm going to ask you to think during all of these challenges is what is the solution? I'm going to ask these guys for a solution. And then at the end of the evening, we're going to have a call to action to say, like, what are you going to do when you leave here to make situations better for patients and their families that are facing cancer? These three do this every day, all day. I spent about 30 years of my career in the pharmaceutical industry doing this for cancer patients, making drugs, making them easier to get. But these guys, 22 patients today, Dr. Rose, did I just overhear you say that?
I am a nurse practitioner. I saw 31 patients.
Oh, goodness. Yeah, it's a busy day for these guys. And once again, each patient is an individual and each patient has their own challenges. So we had quick introductions. So why don't I just start off by asking the panelists in kind of a quick fashion, where do you see, what are the hidden burdens of cancer? Give me your quick perspective, and then we'll dig in from there. Dr. Rhodes, you want to start? Left, right.
I'm not muted, right? Okay. Well, I was thinking about this. I was actually thinking about the fact that this is just such a complex system to navigate. And so when I think about it, there's sort of almost 4 tenets of it that I think about it: the financial complexity, the complexity for time, the complexity for insurance. Because I think that ends up being a huge complexity that we know about, but often don't see about. The psychosocial complexity of a new diagnosis. And then I think about like the community complexity for patients, their caregivers, their friends, their family.
Great. Thank you. Amy, top line?
Yeah, I think that no one is prepared to hear the words they have cancer and to really process what that means for themselves and their family. And so I think oftentimes the emotional and social impact of the disease is just a starting point. And then people are brought into the system that is highly complex in terms of language, the financial arrangements around it, access to care. So I think there's many layers to this, but it really starts with, before treatment ever does, a person and their family's emotional response to what's happening. And I don't think we all are even thinking about mortality. But cancer is a life-threatening disease until it's not. And for many, it takes a long time to even know that. For some, they're never done with this because they're dealing with advanced cancer. So I think really starting from the patient perspective, which is the life is complicated and cancer just made that more complicated.
I think about all the could be.
Yeah.
I think about you talk about some of the cancer journey because there really is this road that we walk with our patients, and at each step along the journey is just terror, right? The terror of a diagnosis, what does this mean? Do I wait? Of finding the right doctor, am I getting care from the right person, the right thing? Trying to choose a treatment course. How do I know this is the right thing to do? Fear of missing out, and what if there's something better? And the terrifying choices we have that we make with us. Then doing that. And then what comes afterwards? And really after treatment, whether it's monitoring or whether it's therapy. It's a terrifying journey that we ask our patients to walk with us and vulnerabilities.
Thank you. And maybe I'll just stick with you, Dr. Matazar, and ask with the great examples. And I heard the words emotion. I heard the words terrifying journey. I heard finance. I heard time. I heard a lot of that. So, Dr. Matazar, as you think about sort of what do you see as the biggest challenge for patients? There are many that they face. You listed several of them. Some people are facing insurance challenges. Some people are facing, sort of institutional challenges. But as a physician, when you saw patients today and you think of one, use some examples of maybe from today or maybe from the last couple of days where you see a big challenge, and how do you help those patients overcome those challenges?
So I guess I'll echo what Dr. Rose was saying, that not only are these really scary diagnoses that are life-changing diagnoses, but they're existing in the context of a life that was already usually overstuffed and stuff. Like, we don't have any room in our lives for something new, let alone something like this. So on top of all the other challenges that we're asked to face on this, now we have to deal with cancer diagnosis and talk about choosing the treatment and making time for that treatment. And what if I'm sick? And how am I going to take care of my children, take care of my parents, take care of myself, keep earning money or keep supporting the breadwinner? Like, the integration of a cancer diagnosis into a life that's already full is sometimes just an impossibility.
Good. Amy, you want to go?
Sure.
I often tell people that, life happens between medical appointments, right? And that's what we're involved in on a day-to-day basis across Western Coast. So as we screen people weekly at home for things like stress, risk of depression, social needs, I think people would be surprised to learn that one of the top issues that people escalate for, meaning that their distress is at a level that it could impact their health and care, is isolation and loneliness, housing instability, lack of transportation, not having enough money to put food on the table, not having enough money to go to the doctor, not understanding the medical information being provided. These are the things that are being escalated to our clinical team to provide interventions to usually within the same day, so we can remove these as barriers to care. I often think about all the people that we're not seeing. So these are just the people in our digital program that we can see into their life, see what's happening in real time. What about the millions of other people who are falling off the radar? So we're trying to reach out to those guys. Those are the types of things that we see every day.
That was biggest challenge.
I think a lot of it is.
No, take Amy's mic. Thank you. Yes.
Oh, it doesn't work. Okay. Forget that. I think a lot of it is to Matt's side is coordination. So, and this idea that life happens between doctor's appointments, I think happens very frequently. Matt and I both take care of patients that have lymphomas that may be treated right when we need them or may not. And there's very different journeys that all these patients go on. But in particular for patients that require CV treatment right away, there's a very large PTSD, I think, that comes with, I just got this diagnosis and Dr. Rose is sending me to the ER because I need to start treatment emergently. And then, we get through 4.5 months and they're like, wait, what you do? And so I think I saw one of these patients today, so that's at the top of mind. And so I think it's the things that we have our patients do and the trust that we have to put in them, in all aspects of their life, whether it's supporting their, doing supportive care for their nausea and vomiting, they're super constipated, they develop a fever and need to go to the hospital, supporting their family while they're in the hospital, thinking about how much parking costs and how am I eating, from day to day, and how do I get to and from the infusion center, and need a CAR T cell, who's going to be my caregiver, all examples from today.
You're caring people, by the way.
Okay, it's complex, and that's like why the complexity of the care that's required these days with a cancer diagnosis has changed so much because we went from in the 1980s to having 5 drugs, and I only know this is true from a mentor of mine who said I have only had to know 5 drugs for my boards. He goes, there were 5 drugs that were approved this past week. So it's just as we get better at taking care of patients, it does become more complex. And the challenge is how do we absorb some of that complexity so patients can process it.
Can I just follow up with something on that?
So the other thing that we see oftentimes is that there's comorbidities, right? So people just don't have cancer. They have cancer, they have heart disease, diabetes. So now they're seeing multiple doctors for different issues. And that's added to what they have to deal with cancer. So I think that's another part of this, which is it's usually not just one thing.
So we've laid out a lot of big bummer topics, and let's get to. We're gonna go up and down. We're gonna go up and down today, but maybe Amy, since you have the mic in your hand, what is your role? What is the role of Crossroads for Hope in helping overcome some of these challenges? I see what you do every day. I don't think this audience sees what you do every day. So tell us a little bit about your organization, what you do, what kind of people come to you, what do they say, how do you respond to them, and how do you help them overcome those challenges we've been talking about?
So for 25 years, we've been supporting individuals diagnosed at any age, and there are caregivers and family members in charge of providing support, information, and resources, and professionals like social workers, life professionals, and other individuals within nutrition and public health to help people live through cancer and help. So we're working towards a world where these services are accessible to anyone, anywhere, regardless of where you get your care. What I would tell you is that oftentimes we provide referrals, people self-referral. Oftentimes a friend or family member will refer to us. And once an individual does make a connection with our clinical team, we meet people where they are. So from a social work perspective, that starts with the person in the context of their life, family, and community, what are their most pressing needs. And oftentimes, you have to deal with those pressing needs before you ever get to the issue related to cancer. And so it's everything from people can't work now, or they're having a problem with relationships with family because of the diagnosis, or they have a child with a disability and are now caring for the child and themselves or a loved one. So these are highly complex psychosocial issues, and what I would say is important is we're not one and done. So we start with people from pre-survivorship, who are just worried about cancer through diagnosis, treatment, survivorship, palliative care, end-of-life care. So we're with people on the whole journey, no matter where they get for care. And that's more like a lifeline. So I can tell you about the individual things that we do, but I think the most important thing we do is we're always there when we're needed. And that lifeline, that touch point is essential when people feel their life is out of control.
That's great. So stability, I think, is one of the things that I recognize that Crossroads for Hope does for people from across the journey, and not only at diagnosis, but also at each of those touch points. And I think that's really amazing, Amy. Thank you. Joanna, do you mind talking a little bit about your role? We had a bit of a prep session about this conversation, and these are busy physicians. They see 30 plus patients a day. How is it that you can help people if you're seeing 30 people in a 10-hour period? That's a lot.
So I see my role as twofold. So one, my role as the physician and my team's role as sort of the medical portion of this is to ensure that patients know what their diagnosis is. Sometimes that can be the first big step when someone comes, whether it's first person they're meeting or a second opinion. And within that role, it's to lay out the care plan, whatever that may be. But then I also think it is part of our role as a medical team is to try and start to flag some of these issues. So is there something that somebody says that makes me think that there's a mental health struggle going on and maybe more support? Do I notice that there's something from that somebody says that makes me worry about housing instability. Are they distressed? We have distress tools that actually flag automatically within our own system as part of our cancer center accreditation, and trying to ensure that patients are pointed in the correct directions to get that kind of help is part of what I see our roles as. We're not perfect at it, and I think that that is always hard when you realize you've missed something that maybe you should have caught earlier when it becomes a problem from a psychosocial perspective in terms of being able to provide support.
Manazar, your role, your team's role?
Joel, can we use your microphone throughout?
We can.
Yes, that's
Take
it.
that.
Thank you.
I'm fond of telling my patients that this is their journey, right? This is their mountain to climb, but I'm their Sherpa, right? It's my job to drag the bag alongside them and make sure that they're sticking on the right path and they know the direction that they're moving in. That's a gross overstatement because it's not me that's the Sherpa, it's my whole team. And this is one of the advantages of working at a place like the Rutgers Cancer Institute, where it's not just the doctor sitting next to the patient, it's the whole team, right? Our nurses, our practitioner partners, our pharmacists, our incredible social workers. There's a lot that goes on behind stage to make the opera look so pretty on stage. And you really need all of these because this is a team sport that we're engaged in. And it only works well when you have all the resources to be able to help patients stay on that path and to climb that mountain. But it's always their journey, right? It's our job to make sure that we don't lose sight of that, but always to be there all the time.
So, Dr. Manazar, you're the master of metaphor. You talked about mountain climbing, Sherpas. It's great, but it is. I mean, I think the way you describe it is, on a very positive note in a very scary situation, is recognition of other challenges. As Amy said, there's a lot to think about after a diagnosis. Your light bill is probably not the thing that you're going to think about. And I think that's where some, like social workers and other people are going to recognize that on your behalf. Yes, the physicians are part of the care plan and driving the care plan, but I think it goes so far beyond that. So positive notes. Now we're going to dive down a little bit into the challenges once again. So, and these next questions are for Dr. Rhodes and Manazar from a physician perspective. And my question is, does it ever feel like any of these challenges that you face are wildly out of control, like insurance coverage or institutional policy and practices, or late referrals or family decisions, and like all of these really super challenging pieces? Are they out of control? And maybe some examples would be helpful.
Sometimes it can feel like to steal a metaphor, the train has gone off the tracks and you have no idea where the train is going. I think that those are the frustrations that we all deal with every day. Being a part of a large team means that there's a lot of people that help with that from my perspective in my own clinical practice and probably in Matt's too. But in terms of insurance approvals and the time it can take to do that for chemotherapy, or the time it takes to get oral medications through and the prior authorization and the number of touch points that there need to be to do something that is standard of care can feel very overwhelming. The other challenge is that nothing ever feels like it happens fast enough. And that's actually one of the hardest things, I think, when you meet a patient for the first time and there's in the process of getting to the diagnosis, it's actually the line I say, I wish I could get this done faster, and I'm going to do everything I can, but I can't get you an answer tomorrow, and I can't get you one right now. And that's the hardest thing, because we're in a system that it takes time to get appointments and then for turnaround, and specialized tests take time. And so I think, and all of those things are necessary to provide, the right care for patients from the medical perspective. And that's not including some of the other stuff that happens in the background.
Dr. Manazar, how are your trains running?
I think that my answer to you is no. I don't often feel like things are out of control. And partially because we have a lot of stuff keeping the train on the tracks, right? We have financial counselors, we have wonderful pharmacists that work with us to make sure that every resource is being tapped to help make sure that we're defraying the expenses of treatment. We have an incredible administrative staff working backstage to try to help coordinate. We do a lot to keep it from being out of control. The time part is really real. That's just real. When we take our tests to like get our MDs, one of the tests is like you have a little computer in front of you and you work through these little simulated cases. And you have a little option on that to like skip forward 4 days until I get my results. And you just click the button and poof, it's 4 days later. Nobody's life is like that. Everybody has to wait those 4 days for those results. And it's terrible waiting. It's terrible for us as doctors. It's infinitely harder for patients and the people that love them. So yes, I often wish that life came with fast forward buttons. So we do what we can to fast forward it, right? We advocate, we bake brownies for the people in scheduling. We try to align things so that if you're coming for one test, you should come for all your tests that day, so you don't have to drive back and forth. Come, get your CAT scan, take the elevator up, see Dr. Rose in clinic, get your results in real time. So you're not waiting a week wondering what your results look like. We do what we can to try to acknowledge these very real challenges and do what we can to combat them. And I think it all.
Back just because I think the people online need to hear me from the mic. Things are rosy down on the end down here. The trains are running just fine. I think, Dr. Rose, you said timing is an issue. The fast forward button is an interesting concept. You don't have that. One of the things that you said during our prep session is we work in an institution that, like imaging is on the floor below us. We can go up and down in the elevators and get things done. It's not that way for all care providers, right? So can you tell this audience a little bit, perhaps, what you might see here that's working well, that might be able to be translated outside of this institution?
Yeah, I think we were even talking about this earlier. So we are very lucky and blessed in the Morse Cancer Center to have, I think, a great team with a lot of support. As Matt pointed out, this is not just about doctors or nurses or nurse practitioners. Our pharmacists make sure that these prior auths that I just complained about actually get done. We usually don't have to touch them anymore. I used to do every single prior auth for imaging, oral drug medications, IV drug medications, where I came from previously myself. And so that was always a bit of a challenge. It's much, much better here. We have an incredibly robust social work network of taking care of a lot of patients that I think otherwise may fall through the cracks because of lack of transportation, lack of funding, lack of the ability to advocate for themselves. So we have a lot of people who are part of their care that are able to advocate for them. Oh my goodness, there's so many good things about living here and having our team here. In my own clinical practice, somebody comes in and they have a new symptom. We're often able to get them same day imaging. I had somebody who I sent down for, a CAT scan to rule out a pulmonary embolism. They didn't have to come back. They just went straight down. They were able to make it work. I had results within 30 minutes. Able to call the patient, reassure them. So all of those things, I think, lead to better outcomes for patients, right? Like I know right away whether or not you need to start a blood thinner or not 3 days from now, where you potentially have now also gone to the ER as well as my office. But I think also is a reassurance to patients of how much we care about what we're doing here and how much we care about their outcomes and how much we want to advocate for them within our own building, so to speak.
Else?
Question already. I was listening to Joanna speak.
More about your role in solving some of the challenges. You talked. You didn't think that there was necessarily a big challenges because of the teamwork that you have, and your role, your team's role that helps patients overcome that. Fast forward buttons aren't there. Is there anything else that
you were also asking about, like the differences between getting care at a comprehensive cancer center versus a community oncology clinic? And this is increasingly challenging, right? Because we know that in America, the vast majority of people with cancer are taken care of in a community oncology clinic closer to their home. And there's lots of reasons why that's a good thing, right? As my boss, Dr. Moody, likes to say, cancer doesn't travel well, right? Nobody wants to schlep around. They may not even want to schlep to New Brunswick, let alone to schlep across rivers or lakes. And yet we recognize that with the increasing complexity of cancer care, that not every community oncologist has all of the tools that they need to be able to deliver sophisticated and complex care to sophisticated and complex patients. I think within oncology, we're getting better about this and about breaking down some of these barriers. That's one of the good things about working within a health system like RJVH is that we have 12 hospitals across the state, and we can work relatively seamlessly even to some of our smaller centers across the state and make sure that they're able to tap into the resources here in New Brunswick, here at the Morris, and make sure that we can get the doctors who are the ones taking care of patients closer to home access to the right expertise, to the right resources, so that they can do the right things for their patients without making their patients have to find a new doctor, go through the disruption of breaking up a very good relationship with a doctor to be able to get sophisticated and thoughtful opinions.
So, Amy, if I can ask you sort of similar questions, you talked a little bit about the challenges, and I've seen examples that you've shared with your board about people who come to you kind of at the end of their life or at the end of what they think is their life. The tools and the resources that Crossroads for Hope has are phenomenal, and your social workers and your navigation teams are really helping people. Talk a little bit about the tools you have, the resources you have, and perhaps a couple of examples where you use those tools and resources. And I have a couple of thoughts from the things that I've seen you do as well, as like the long-term points of contact that you have with people from pre-diagnosis and diagnosis all the way through survivorship to the end. And they're touch points all along. Perhaps talk to this audience about not only the tools that you have, the impact that they have, perhaps with some examples. And then a last question is, how can institutions like this partner with your organization to make sure that patients get access to those?
So 90% of oncology care is delivered, as you said, in a community-based setting. Most of those settings have basic resources. And, from my perspective, one of the value propositions that we offer as an organization is that our clinical team is made up of social workers. So this is what we do every day. And it's more than navigation and connecting people to resources. It's about really understanding what's under the surface for people. And, so we serve nationwide. And so we're getting referrals from providers all across the nation. And oftentimes in communities where there are no resources. And so I think what's really important is our system, our approach is built with the patient and family first. And so we're really about understanding what the most pressing needs are. So our social work team is really operating at the top of their license to understand that and to then help start to guide the family, guide the individual on what's the first step. How do I start taking those first steps to get through the initial shock, the initial issue, so that I can become empowered to take in information and become part of the healthcare process where I can advocate for the best care. I think I'll give a quick example of something that happened recently. We had an individual come to us who had been in and out of different cancer centers. And when we finally connected with this person who had been referred by a family member, it turned out that this person actually was suicidal. And not only was the person suicidal, the person had a plan and had access to a weapon. It was a young person in their 20s who thought that their life was over because of this cancer diagnosis. And so when the social work team was relaying this case to me, I said, what did you say that led to this person opening up to you? And Kyle and our team said, I asked the individual how they were doing. It was as simple as that. So my concern was, in this person's cancer experience and journey, there was no space for that in any of the care that that individual had received, where they felt trust enough to say, this is what I'm thinking about. That is an extreme case, but it really exemplifies the power of starting with the person and creating a trusted space, not about the disease, not about the treatment, not about the money, but about them in their life so that we can meet those needs. I think the best way that people can connect to us is by calling us directly. You'll get a human being. Providers are referring electronically to us. People literally can still walk in. I think my clinical team might be on the call here, so they're probably rolling their eyes right now, but literally you can walk in and talk to a human being. And so from that perspective, it's very personal and very high touch. And I think for most people, something that they're not used to in the day-to-day average healthcare experience that they have. So.
All right, thank you for that. And I'd like to move into sort of another sort of challenge solution dialogue. Dr. Rhodes, you talked a little bit about sort of, when you opened up, you said, you know, there are sort of 4 things that you feel are big challenges. 2 of them were in the finance arena, sort of it's money for care, it's navigation and payment for insurance. Think about those 2 elements. In thinking about that and helping people navigate through that, where have you found the best place to intervene? Is it your job? You said you used to take care of prior auths on your own. Now you've got to staff people to do that. How much is it a patient responsibility? How much is it an institutional responsibility? Or how much is it all of our responsibilities to vote or, you know, move policy in the right way so that you can overcome some of these financial barriers and insurance barriers that patients face?
Can I say all of those? Because I think they're all important in their own right. I mean, I think from my perspective, patients will ask me about specifics about their insurance, and I just don't know the answers. And I'm very honest about that, but we have financial counselors, we have an insurance office, and I often will refer patients to that. I think a lot of the burdens of insurance do fall on patients. I don't necessarily think that's right, but I think that that is how the system has been built. I think it's probably upon all of us to try and perhaps fit that burden, because who has time in their very full life while also dealing with a cancer diagnosis to be like, are you in network?
Yeah.
What's my copay? Was my copay for this bag of IV fluids going to be the difference between lights or no lights? That my doctor says I need because I feel really terrible. I don't have the answers to that. I think coding is a very important thing. Our healthcare system is not necessarily one that is easy to navigate, and I don't think that that's been done for a reason, but that is perhaps a little bit more political than we would like to get today. But I think that all of those tenets are important when we think about how do you navigate the finances of insurance and a cancer diagnosis.
Great, thank you. You want to put that?
Absolutely.
I just to follow on to what you're saying, having started my career in human resources and helping people enroll in their health insurance, and when we went to cafeteria style plans, I'm like, nobody's going to understand these plans if they're not made for the average person to understand, period. But I think when you're talking about this kind of a diagnosis, I'm talking not just as a professional, but as somebody whose husband went through this 2 years ago. It's hard to know what to do. And I think, I've been in a situation where there's trust between the doctor and the patient, my husband in this case and me, and the insurance company overrides or delays or says, you're not going to be able to get this screening that will, determine whether or not your cancer is spread or not, and pay for them. And so what do? I don't think most people understand that they can appeal these decisions. They can advocate, they can call their legislature. They can do a lot of things, but I think voting really does matter because at the end of the day, these systems have been built and they've not necessarily been built for us. And so it's really important that we have people who understand what healthcare should look like and how payments should be handled, and the burden should not be on patients and families.
I'm an extremely political person.
All right, we just open the door.
But probably out of scope for tonight. But I'm happy to talk to you after. I think that the physician has an important role in this. And even though, often when patients come to us, they're already ill and in need of care, and they already have insurance or don't. We can't unring that bell. But what the physician often ends up doing is being the advocate in chief, right? So we all know that insurance companies want to deny, defer, delay, do all the things that enhance their shareholder value and don't enhance my patients' lives. But we can fight, and we do fight, and that's partially what our job is to not put up with bullshit and to insist on appeals and making the calls. And have there been times that I've threatened to go to the press? Yes. You have to do what you have to do because our role is sacred. And if you believe that what we're doing matters, which we do, then you have to sometimes roll up your sleeves.
Just say one other thing about that.
I think what's really important, I'm sitting here next to two doctors, is they went to school for a long time. They are licensed. It is really disturbing to have somebody who's never met you, who's never evaluated your care, override their decision. And I think we all have to think about that. I mean, if we don't need doctors at that level of care because somebody who hasn't seen us is going to make the decisions, then you can just skip medical school, which nobody would even advocate for. So I think we have to trust the people who've been trained and licensed to do this, and not maybe somebody who's never met us.
Amy, I'm going to give the mic back to you because I asked the two physicians a little bit about sort of like how they navigate the insurance and the financial world. Amy, a lot of the questions and the dialogue that is happening between your social workers and patients is more on the social and psychosocial front. And you can add to that. Tell me a little bit about, like, is it a social worker's responsibility to solve that problem? Is it the patient's responsibility to seek help for that? Same kind of question with the broad spectrum of potential people that could help solve the problem, or maybe those that have the greatest ability to solve it. So tell me a little bit about your thoughts on who can help solve those problems and how you work together to solve them.
So unfortunately, the burden is on the person who's diagnosed with their family because they hold the insurance and they're the policyholder. But there are professions like social work that can help people navigate those issues. I think from my perspective, it's really important to understand that, people can be given the tools to self-advocate. So once you can get somebody's emotional state level set, meaning their distress is being managed, they can start to take in information and advocate. So we do have conversations about what you need to think about as you prepare for a treatment decision. If you need to talk to your insurer, what kinds of questions should you be asking? We help people enroll for insurance under, Medicare and other policies that are having difficulty. And I think that all of those services are important, which is why we advocate on the national level to elevate social work across the board. We're a community-based organization, but social workers are trained to help people, not just with these practical issues, but with surrounding all of these issues, which is all the emotional burden that comes with that. So when you get declined from your insurance company, you're angry, you're upset, you're afraid, because treatment might be delayed as a result of the fact that you cannot get the treatment that your doctor is saying you need. All of those things have to be managed for people. People need help being managed that. So I think from my perspective, if we want person-centered care, you have to have professions who start with people, and that is social work. I'd love to see a social worker in every single visit with the doctor so that you don't have to translate conversations. The person is hearing things in real time. And in some of the best centers that were used as the basis for the Affordable Health Care Act, that was the model where, you know, a person comes into the system and they get a nurse, a doctor, and a social worker, and sometimes a therapist. And that's the team. I started my nonprofit experience in a hospice. It was a nurse and a social worker, a co-managing care. That is the best in class model of care, and we need to see more of that, especially in community-based settings.
So a little warning to the audience, get your questions ready if you have them, because I'm going to open this up. I'm going to ask these guys one more question, but if you do have some questions, I have plenty of them and we can talk all night long if you'd like. But if you have some questions, I'll open it up to you in just a couple of minutes. And we can use my mic or we can figure out how to use the other mics. Dr. Manazar, you brought up an interesting point about sometimes things get you to the point of wanting to make a change quickly or a drastic decision. You said go to the press. Can you describe perhaps, and anyone on the panel can describe this as a patient care situation or a social work situation, Amy, that made you so mad, so angry, so upset that you really needed to make a change immediately or threaten a change immediately so that that patient got their problem solved and any other patient thereafter, that problem was solved for them as well?
The latter is magical thinking, right? There is no fix that I have in my hands that can prevent problems from happening again. Not that comes to mind, right? We often are putting out fires one at a time, which is inefficient. It's not systematic. It's not how we want to make the world a better place. But at the end of the day, you know, as I know a patient, when I'm sitting with you, I have one patient. You're my patient. You're my only patient until I'm in the next room, and I only have one patient. And sometimes problems are fixed one patient at a time. Not every problem in life is life and death. But unfortunately, oncology, some of them are. And there's times that you have to go through the process, and there's times that you can't. And that's part of our responsibility is to know which is which, and to be able to say this is a life and death decision, and there is no. So let's just talk about what yes looks like, and make sure that we have that in hand. It's not going to be every time, right? If you're the boy that cries wolf, eventually that doesn't work. But if you have credibility and you have integrity and you're making the right decisions for your one patient, then it's going to be okay.
So I agree, there's no magical thinking. I wish that care was more accessible earlier so that we could screen people and get to people earlier in their cancer journey, because we see a lot of people being diagnosed at later stages. I think the thing that gets me the most upset is when, you know, everybody struggles who's diagnosed with cancer. It doesn't matter your income, it doesn't matter your insurance, you're going to struggle. And so you have to just imagine if you have somebody with, you know, company insurance and they're making a six-figure salary and they're struggling, can you imagine if I don't speak the language, if I don't have that income, if I don't have the resources? What really bothers me is that how people are treated based on their income. And I'll give you a quick example. So we issued financial assistance across the country. And we had a family in one of the southern states, I won't name the state, and we issued financial assistance. This person had a child with cancer, other children in the home, and they were going to be evicted. And we issued a check from a legitimate bank in New Jersey, and the bank would not take the check. And we were running out of time because this person was going to be evicted from their home with a child with cancer. And it was because the bank didn't trust the check, because of the person. And when I tell you that that is not a unique situation, I've seen, you know, people on charity care being told, you know, you won't see the doctor for 10 weeks, you know, with fear that their cancer had recurred. And they know that they're not going to last 10 weeks. So I think from my perspective, as somebody who considers himself a humanitarian, you know, if you want me to go to the press and scream from the rooftops, it's for those cases, because for no other reason than who you are and what your income is, your life is on the line. That's the kind of stuff that just, yeah, that's what we see. That's what we see.
I don't know how I follow that. I think a lot of these are one-off cases where we're kind of going to the mat for a patient. I think they happen more frequently sometimes than I would like. And it depends honestly on the week, I feel like. Some weeks are better than others. I don't know if all the insurance companies like to do the same things on any given day of the week. They all really coordinated to really grind my gears. But I think that the reality is that when these things happen, we all kind of band together. I can think of one where I think I screamed at a CMO about paying for a standard of care medication that's been FDA approved since 2000 and like refusing to pay for it. And I think I scared them. I personally write down every denial comes with the person's NPI number and the chart. Because my feeling is that somebody wants to make a case about that. Somebody else made a medical decision on my behalf. That's not in line with mine. So those are and I find that just sometimes is a little bit effective in getting what I think is appropriate care. So I think that there are ways to do it, but it is inefficient. And I think that that's the challenge. And there's another person waiting for you to get that done. And there may be 5 people that take waiting for that to get done. So I think that becomes challenging and very hard.
And can I just say something too? And so when you think about the cost of care and what's required to just navigate these systems in the healthcare system and in other places, the administrative staff, the other resources that are required to, file appeals and, do the follow-up and, that is adding to the cost of care. And that's the care that we're paying for. And so I think it's really important not to lose sight of that.
I would even add, not only does it add to the cost of care, but it detracts from the quality, right? Every hour that Dr. Rhodes is spending yelling at CMOs is an hour that she's now spending where she wants to, which is sitting knee to knee with her patients talking about how to navigate their illnesses. So there's hidden costs on our end too, because there's only so much of us to go around.
Great, thanks to all of you. I want to open it up to you guys to ask any questions to any of the panelists. Yeah, if you come back here in the brown sweater.
I just wanted to say thank you first for the organization Cross for Roads. My name is Margarita Silva. I am we come from Trinidad Hospital, and my role is to be a breast patient navigator. And my colleague Yaelin, she's the community navigator. So one of the important I appreciate because your organization is helping us. As you mentioned many things with the solutions about social workers and educators and the nurses, but unfortunately, what you can do if you don't have those kind of services? Not every hospital is still functioning completely with the full staff. And the navigators is playing the role of the social workers. And I am very happy that with this organization for the help, because without them, I don't know how I was able to support my patients, because the value of breast cancer patient is really high. And in addition to this, I just would like to add some solutions, because you present the problem as a doctors. I love the fact because I work close to the doctors also. But based on the experience that I have as be working also in the admission department, I know very well about insurance, how they work, and also what is charity care and other financial problems. But I just wanted to specify, especially the ones that you mentioned about the charity care patients, the situation for them, because there's no insurance for them. Okay, and I am talking about the minorities, because I see that the majority of you are legal Americans, but we deal with a lot of group of immigrants. And I just want them to be seen like human beings, because apparently we are treating them like from where they come from. Let me give you an example. For example, I am from Ecuador, but I'm a legal citizen, even though my parents is Spanish, but maybe Yaelin is from Colombia. Let's say that I have cancer. I was diagnosed with cancer and I had 2 children. Yaelin same age, almost around me. She has two children as well. She doesn't have a husband. She's working in cleaning houses. Okay, I'm lucky because I have papers. I have a husband and I have a job. But this patient, Yarini, the fact that she doesn't have a husband, she's alone with the children. She becomes basically the primary supporter of the house. But she's illegal. She cannot qualify for Medicaid. I can ask her to apply for any government program because she's going to be denied. She doesn't have for food stamps because of the scene that she's an immigrant. I cannot send her to buy medication because she has to pay by her own. So that medication would cost her money. But I'm the lucky one, the Ecuadorian girl, woman who has two children. I have access to unemployment benefits. I have access to food stamps in case if I lose my job. I have access to unemployment, even to disability, because when they do the surgery, something of me or chemo, I can always apply for disability. So this person, based on her status, doesn't receive anything. And she's another human being. So is that right that she cannot apply for anything? She's here. She was cleaning house. I have a patient 75 years old who recently had been diagnosed with cancer. She came to my office and I said, Margarita, I worked here for many years. And I went to social security, they told me that I can even take it like 1,700 a month. I said, and what does for me? Where's your insurance? I don't have it. Where is, do you go? She says, I need glasses, I need dentures. I said, listen, why don't you qualify? Because I don't have a paper, I don't have something that can prove my legal status. So she pays taxes also as well. Another situation, but I don't want to, because I know that you don't have too much time. But I just want you to think about it. And also about the solution, I've been working with, I remember working many years in the emergency room. And I don't know if all of you know that there is a Medicaid, emergency Medicaid, right? For 3 months, when you have certain condition, you can qualify for Medicaid emergency, right? So why don't we fight? I'm encouraging today and inviting you to fight that when somebody is being diagnosed with cancer, we can advocate that they can get as soon as the application has to be approved as soon as possible. It has to be considered in the same category because cancer is a disease that kills. It's an emergency. But it takes so much time for the insurances to approve something like a number, right? I worked with Dr. Vega, I was texting her before when we started the meeting. And I said, what do you want me to say? She says, exactly, Margarita. Sometimes she says, I want you to, please, Margarita, working and doing the MRI. But you know what? I do magic like doctors makes us do your magic. But, unfortunately, when I mean, if you don't know how to say it or go to the right diagnosis, they are not going to approve it quickly. We don't have a line with insurances that is allowing for us, for the healthcare employees, to call on the representation of the patient that allows us to force them to approve the certain test when it's cancer. I have, for example, that I can see that works. For example, I get along with the radiology department here, all of the resources. I know myself, my greatest son. I said, you know that I cannot wait. I love you so much, but I need Mickey Mouse to have a test as soon as possible. I know that you have 10 patients already for Tuesday, but Mickey Mouse has cancer. So when you have connections, it's possible. But what all we need is to get together as health workers and fight for the rights of these patients.
we need a line to force the insurance companies to take care of our patients as quickly as possible when they hear the diagnosis of cancer. In that, we can use the VIP and the doctors who are our resources are, they have the knowledge. I mean, just giving a signature that that's all we require in order to prove insurance that patients have been diagnosed with cancer. I don't want to take a long time. Thank you so much. And
Thank you, Margaret.
this is over.
That's great. Amy and her organization that have been doing some amazing work with those that are less fortunate. I don't know, Amy, if you want to talk a little bit about that or respond to her comments.
I think, what she's expressing is what I was saying earlier, which is, the system is not equal. And that translates into high risk for patients and a high likelihood that they're going to die from treatable diseases, which is what we see every day. Insurance is just one barrier to care. So I think, from my perspective, this is about having an equitable healthcare system that provides support and resources to patients when they're healthy and when they're sick, right? And we shouldn't have to fight so hard to get what is essential, basic human care. So thank you for sharing your story.
I'll say a few things. First, Viva Ecuador. My wife is Ecuadorian, born in Quito. Part of why I came to Rutgers, I spent most of my adult life working across the river Memorial Sloan Kettering, and it became increasingly morally untenable for me to stay there because we were only taking care of the wealthy. And it felt like a moral failure to me. So at Rutgers, it's different. We are the single largest deliverer of charity care in the state. And we have a lot of resources to take care of people because they're human beings and not because they have papers or insurance. And our ability to deliver the very highest quality and most sophisticated care to people because they're humans and not because of their insurance or their documentation feels like a moral good. And yet that's only one part of it, right? So we can give somebody CAR T-cell therapy, bioengineered T-cells to treat a lymphoma, but it doesn't fix the fact that our country dehumanizes them. And that a patient who had just received a stem cell transplant on charity care, but is asking me for papers in case ICE gets him, that he could show them that he can't be taken because he's just gotten a bone marrow transplant. This is our country right now, and it boggles the mind, and it's who we are. So vote.
All right, we are a couple minutes away from the bottom of the hour. We said we'd be here for an hour, and I think we can be here for a lot longer. I'm going to ask one last question in the final couple minutes, and we'll be around to talk to you afterwards as well. But in the closing couple of minutes, just a very quick question. We've gone through sort of the highs and lows of cancer care. There's been a lot of analogies and metaphors, and they're fantastic because it helps us understand. But as you look at this audience in front of you and online right now, what would you like to tell them so that they can take a message home that will assist them in revealing those hidden issues, but also help solving for those hidden issues, hidden burdens. So in a couple of minutes, what is your call to action?
I mean, I think a lot of it is just advocacy. So whether it's myself advocating for patient with an insurance company, someone on my team advocating for patient to get to a resource that they need. But I also think some of it is these hidden barriers to care. Sometimes we don't get a chance to address it every single visit. And so if there is something going on, I think there is some self-advocacy that could be helpful to remind us of that what the medicine is there for, but also the person behind it. Right.
I think the message I'd like to leave people with is you're not alone. And that's why our organization exists. So Crossroads for Hope is here for you and your family, no matter who you are, where you live, and no matter where you get your care. And I also think it's really important that people understand that we see you, not your disease. And you are a human being that deserves quality care. So no matter where you get your care, when you come to our organization, I want you to know that we see you and your family first, and you are the priority.
my hope is that hidden barriers are a thing of the past, right? We don't want these barriers to remain hidden. They can't. That means that we all within the work that we do need to continue to address these barriers and and move them behind us. And it means that patients, caregivers, their loved ones need to believe that they deserve better, right? And you need to believe that if you come to your doctor, your social worker, your case manager, your caregivers, and say, I have a problem, I have a need, I have an issue, this isn't working, I'm ashamed to talk about it, or I don't know if you're the right person. Just, we need to ask the questions and you need to ask the questions too. And this is a journey that we're on together. And if we are open with each other, communicate, and trust each other to do the right thing, I believe in progress.
Just on that, I just want to say, like, you can listen to what we've talked about and say, oh my God, how do they do their job every day? And I can tell you, I do my job every day, and I'm sure you do as well. I have hope. I have hope because there are people in the system who are trying to make a difference for patients and families. And I have hope when I look out at this audience about the people who care about this topic. So it's, to me, we talked about the ups and downs, but in the end, that's where I land.
Great. Well, first of all, let me close in thanking all of you for being here. Closing with our panelists who've been fantastic. Just a couple of summary points for me. We set out with a goal to reveal some of those hidden burdens. Yes, we did spend a little time at the bottom of the cancer journey where are the challenges, but I think the hope, the fight, the magicians that are around this room and the partnership that I think that we see from your three Sherpas across this group up here is fantastic. I think, we've talked about this, cancer is a journey, and cancer is a mountain. It's a journey. It's a journey upward, and I think with these Sherpas and those that are around you, you can conquer that mountain. Yes, there are trains off tracks, but there are trains that also can take you places, or processes that can take you places that are a bit of a fast forward button that can help you navigate the cancer situation, whether it's through social work or talking to your physician about a care plan, or making threats if necessary, and also helping those that are really less fortunate. So, ending on a very positive note, I want to thank you for your thoughts, your prayers for those that these guys are treating, or all of you are treating, but also your hopeful thoughts as you go home. And I'll ask you to start that same question as you leave. What is it that you can do as you leave tonight to help those that are facing cancer? Thank you very much, and have a great night.